My focus today is going to be on the science of surviving cancer, and I'm going to focus primarily on childhood cancer because I am a pediatric oncologist and that's my passion. I do study adult cancer outcomes as well, primarily in the bone marrow transplant survivorship related areas. So let's get going. Just a few facts for childhood cancer. Each year in the United States, close to 16,000 children are diagnosed with cancer. This means that 1 in 285 children will be diagnosed with cancer before their 20th birthday. Cancer is the leading cause of death for children between 1 and 19 years of age, and you can see this where you see that almost 60% of the deaths in children are due to cancer, followed by a distant second in the form of heart disease, and then a variety of other causes. So cancer is a very important entity within children with cancer, even though this particular number might not seem very large for people who study breast and prostate cancer or lung cancer. So roughly 3,277 children die from cancer each year, and this translates into every 3 hours a child is dying from cancer somewhere in the United States. However, we've had significant improvements in outcome, and what I want to share with you is that before the 1960s, childhood cancer was a uniformly fatal disease. Between 1975 and 77, we were saving about 60% of our children with cancer up to at least 5 years. And then in 2005 to 2011, this particular 5-year survival rate has jumped to over 80%. In fact, it's approaching 85%. So with this tremendous improvement in survival, we can say very safely that in 3 years, we will have over 500,000 childhood cancer survivors. And this improvement in survival comes at a huge price. And that's what the topic of our conversation is today. We know that over 75% of our childhood cancer survivors will develop a complication which is directly related to the treatment that they received for their first cancer. But what's more important is that 40% will develop complications that are serious, life-threatening, or fatal. This slide shows the late mortality in childhood cancer survivors. It's drawn from the largest childhood cancer survivor cohort, the Childhood Cancer Survivor Study, the PIs at St. Jude Children's Research Hospital, which shows that if you look at the survival rates, here are the US female and US male age-matched survival rates, and here is the survival for female and male childhood cancer survivors, showing a divergence and an increasing dip in the survival as time goes on from diagnosis. And what you have to remember is that it's truncated at 70% here. So this is that wide gap, and our childhood cancer survivors are at a 6-fold higher risk of dying than the general population. And roughly this means that the life of a childhood cancer survivor, even though they have survived their original cancer, is shortened by 1 to 2 decades. Another important thing to remember is that there are significant racial disparities in outcomes in children with acute lymphoblastic leukemia, and we looked at this in the beginning of this century in 8,447 children, and what we found was that Asians had the best outcome, followed by Caucasians, Hispanics, and African Americans for children with acute lymphoblastic leukemia, which is the most common diagnosis in this age group. So in this particular talk today, I'm going to focus on two topics. One is disparities in cancer outcomes, and the second is the burden of morbidity carried by childhood cancer survivors. So let's start with disparities in outcomes, and I'm going to focus on the question of adherence, looked at it from the lens of adherence to oral chemotherapy in children with ALL. So let's go back to epidemiology of childhood ALL. This is by far the most common diagnosis in children with ALL. It's about a quarter of our children are diagnosed with ALL as compared to the other diagnoses. The median age at diagnosis is about 4 years, so it's a young age group that gets affected, and the male to female ratio is slightly in favor of males at diagnosis. This is the survival rates that have been achieved from 1968 to 2009 in children with acute lymphoblastic leukemia. So this was what we did in the 1960s, and this is what has happened from the 1970s to 2000, the big jump from 1972 to 75 here. This is where we are right now, and for acute lymphoblastic leukemia with certain diagnoses, the survival rate exceeds 95%. Treatment of children with ALL, there's a very high intensity phase which lasts about 28 days. It's called induction. This is followed by consolidation and interim maintenance, a variety of delayed intensifications, 1 or 2, and then a prolonged about 2-year period of what's called maintenance. So this is the intensive phase. It usually lasts for about 1 year. And this is the maintenance phase, which usually lasts about 2 years, although now there's increasing movement towards making this all shorter. We assess for remission at the end of induction, which is at the end of 28 days. And so in the context of that, over 95% of our children with ALL enter clinical remission at the end of induction. However, when you follow them long term, 1 in 5 relapse within 5 years. The question is why? We have to remember that during the maintenance phase, the durable remissions require 2 years of daily oral consumption of 6-mercaptopurine, which is a type of chemotherapy. So disease-free survival in children with ALL depends on adequate systemic exposure to oral 6-MP, which is determined by pharmacogenetics, by the dose intensity, i.e. how much dose the healthcare providers are giving, and then it depends on adherence to chemotherapy, i.e. how much of that drug the children are taking at home. So our hypotheses were, the first hypothesis was that non-adherence to oral 6-MP results in lower systemic exposure to this drug during maintenance, resulting in an increased risk of relapse. And how did we test this? We measured adherence to oral 6-MP in children with ALL. We looked at the impact of adherence on relapse risk. We designed a prospective longitudinal cohort study. We had children who were less than 22 years of age at ALL diagnosis and were receiving maintenance chemotherapy. How did we measure adherence? We measured it using special pill bottles with electronic track cap to dispense the 6-MP. So there's a microprocessor chip in the cap which records the date and time of opening of the pill bottle. After the end of the study, these caps are returned to the coordinating center, and here the data is downloaded, and each of these blue dots represents the opening of the pill bottle. These are the dates and these are the times. The children are supposed to open it once a day in the evenings. This is between 8 and 9 p.m. So this is an adherent patient. We see tight clustering of all the data. Here's a non-adherent patient where you see big gaps and a wide spread in terms of when they're opening the pill bottles. We also measured blood levels monthly for 6 time points, where we measured the metabolite levels in the red cells of this drug. And we also looked at pharmacogenetics as a one-time blood draw. We asked for self-report of adherence. It was an adherence questionnaire, where we asked for number of days 6-MP was taken and the missed doses over the past 4 weeks. We asked for barriers and facilitators to adherence, and then we tried to identify behavioral predictors through these questionnaires. These questionnaires were available in English and Spanish to the patients. We also asked the parents to complete a demographic questionnaire which asked for the race and ethnicity of the child as well as the parents' education, the household income, the family size and structure. We asked the institutions which were participating to complete what's called a maintenance report worksheet, where they described the 6-MP dose that was prescribed for each day of the past 4 weeks, and the dates and reasons why that 6-MP was held, if it was held. We asked for follow-up forms, where we asked for recurrence, deaths, and second cancers in these patients. So this was the schema. It was over a 6-month period. And just to go over the details of it, on day 1, the patients were consented and pharmacogenetics were obtained. Monthly, from day 29 onwards, red cell metabolite levels were obtained. A demographic questionnaire was completed on day 29. And then the 6MP monitoring using that MEMS cap started on day 1 and finished on day 169, which was 6 months. At the end of it, the caps were brought back and sent to the coordinating center, which was when I was at City of Hope. It was there, and now it's at UAB. These are roughly the states and sites which participated in the study. There were very few states which are light colored which did not participate. Most of the states did. One site in Australia also participated in the study, as did Canada. So 742 children participated in the study. And how did we calculate adherence rate? We took the MEMS cap data as well as the maintenance report worksheet, where we had asked them to tell us which days the doses were prescribed and which days they were held. And we used this to calculate by using a number of days with MEMS caps opening divided by the number of days 6MP was prescribed, multiplied by 100. And from the denominator, we took out the days when the 6MP was withheld by the healthcare provider. So this is what the cohort looked like. The median age at diagnosis was 5 years. The median age at study was 6 years. 68% of this cohort was males, as I said. There is a slight male preponderance in ALL. 43% of the patients had what's called high-risk disease. And then the particular pharmacogenetic TPMT variant, which we were interested in, the wild type, was present in 93% of the patients. So the first question was, do children with ALL adhere to prescribed oral 6MP? And so here we're looking at adherence overall for the entire cohort. Here is the adherence rate, and here's the months on study. And so what we see is that in the beginning, if the patients are supposed to take 100 days of 6MP, they take it on 95 days, and then this peters out to 90 days at the end. So this was our entire cohort, and the time trend was significant from 95% to 90%. We then looked at mean adherence rate by age at study participation, and what we find is that those who are older are less likely to be adherent as compared to those who are younger. These are children between the ages of 12 and 21, and these are less than 12. So there's 92% average, and here it's 84% average. And we looked at by annual household income. Those who had low income had lower adherence rate. Those who had high income had higher adherence rates. Then the next question was, does poor adherence to oral 6MP influence the risk of relapse? And so here we're looking at a very simple way of examining this question. And we have on the y-axis the adherence rates, the average adherence rates, amongst people who remained in complete continuous remission versus those who recurred. So the average adherence rate for patients who remained in remission was 90%. Those who recurred, it was 83%. So lower adherence rate here, which was statistically significant, different. We then said we would do a multivariable Cox regression analysis in which we adjusted for all of the variables that we had available to us, which were prognosticators potentially for outcome. And we then created, each one of these represents a separate model, and we said we would look at a cut point in adherence rate by saying those who had 95% or higher adherence versus less than 95%, those who had 90% or higher adherence versus less, and so on and so forth. And what we find is that using all of these cut points, those who had 95% or lower, the less than 95% adherent, were at a twofold higher risk of relapse as compared to those who had 95% or higher adherence rate. And this was true across the board for other cut points as well. So we used, therefore, 95% as our clinically meaningful cut point for adherence level in terms of measuring relapse risk. And this is what the cumulative incidence of relapse looks like by adherence. Here we have patients who have adherence rates less than 95%. These are patients who have adherence rates 95% or higher, and these two are statistically significantly different. What we also show is that 44% of our study participants were non-adherent using this particular definition. And when we looked at the adjusted risk of relapse attributable to non-adherence, we find that 47% of our risk of relapse is explained by non-adherence. So then let's take a look at the prevalence of non-adherence by sociodemographic characteristics. When you look at race and ethnicity, what you find is 32% of Caucasians, 46% of Hispanics, 48% of Asians, and 66% of African Americans were non-adherent. Age at study, as we would expect, the younger patients are less likely to be non-adherent as compared to the older patients. And then by annual household income, those who had higher annual household income were less likely to be non-adherent as compared to those who had higher. What's important to note here is that even amongst the lowest risk group, we had a fairly sizable prevalence of patients who were non-adherent. And this was what led us to make sure that we included everybody when we developed our study on interventions in this area. But before we go there, we have to summarize our findings. We say that 6-MP non-adherence is associated with an increased risk of relapse, that 6-MP non-adherence is prevalent, and that there are certain subgroups that are at a much higher risk of developing 6-MP non-adherence as compared to others. With this in mind, we said, let's go back to the original question which led to this study, which is, what role does adherence to oral 6-MP have in explaining the racial and ethnic differences in outcome? So we said, let's take a look at the distribution of induction success by ethnicity. And again, we draw upon our study, which we published in 2002, on this large number of patients. And we find that when we look at it by race and ethnicity, there really is no difference. Practically all patients, and it's about, here it's 97% and the others are 99%, are getting into induction as were used, using the parameters that were used in that era. However, you've seen this before. There's a significant difference in outcome, long-term event-free survival, by race and ethnicity. So we then fed this into a multivariable model, and we found that even after adjusting for all of the variables that were known as prognosticators, we had a significant difference in outcome as compared to non-Hispanic whites, such that African Americans have a 39% higher risk of relapse, Hispanics at 37% increased risk, and Asians at 33% decreased risk of relapse. So with this in mind, our next hypothesis was non-adherence could help explain the racial ethnic differences in survival. And here are the characteristics of the patients by race and ethnicity. And so we purposefully oversampled Asians and African Americans, and these were the proportion of patients in our study. And what we find is that there's no major difference, at least statistically significant in this study, by age at diagnosis, by gender, by age at study, by the high-risk criteria that we were able to study at that time. However, there were significant differences in sociodemographics, such that there was an overrepresentation of Hispanics and African Americans amongst those with low income, those with low paternal education, as well as maternal education. And then there was a high proportion of stay-at-home mothers amongst Hispanics as well as Asians, and less so amongst non-Hispanic whites, and least amongst the African Americans. So then the question is, what was the mean percent adherence by ethnicity? And this is what our study showed, that this is the adherence rate for African Americans, for Asians, and for non-Hispanic whites. And this is the adherence rate for non-Hispanic whites and Hispanics. So there were significant differences in adherence, and these are adjusted for all other sociodemographic factors. When we looked at the cumulative incidence of relapse by ethnicity in this study, we find that Hispanics have a 16.5% incidence of relapse, as opposed to Caucasians, where the incidence of relapse was 6.3%. We then said, let's take a look at the determinants of relapse risk including Hispanic ethnicity in the model, and we find that Hispanics have a 2.6-fold increased risk of relapse after adjusting for all the other variables. And then when you feed in race and ethnicity and all the sociodemographic factors, as well as adherence, that particular magnitude of difference drops from 2.6 to 1.8, and it loses its statistical significance. So it does contribute to some extent to that difference in outcome. We then looked to see whether there was an interaction between ethnicity and adherence, and here's what we find. We took groups of patients, stratified them by those who had absolutely high adherence rates, irrespective of whether they were white or Hispanics, those who had between 90 and 95% adherence rates, those who had 85 to 90% and less than 85%. And we looked to see the risk of relapse in whites, in Hispanics versus whites. And so here whites would be at a reference point of 1 hazard ratio. The risk of relapse amongst those who are perfectly adherent for Hispanics is 5.3-fold that of the non-Hispanic whites. For those between 95% and 90% adherence, it's 10.5-fold. However, amongst those who are non-adherers, there is no difference in risk of relapse. So here's that cut point where we say that if you have an adherence rate of 90% or greater, the risk of relapse is higher amongst Hispanics compared with non-Hispanic whites. And if you have an adherence rate of less than 90%, the risk of relapse is comparable. So there is, in addition, something else going on in this group of patients once we level that playing field in terms of the adherence rate. So the next question was, what are the reasons for non-adherence? We looked to see, again, using that questionnaire data, and we find when we look by age, dividing it into less than 12, 12 to 17, 18 plus, that the overwhelmingly large majority of patients reported forgetting to take their medications as the most common reason. And it makes sense, right? All of us forget to take medicine, right? All of us do. Logistics was not such a huge issue, and logistics were in the form of, oh, the pharmacy shuts at CVS shuts at 3 p.m. and I forgot to refill the prescription, those kinds of things. Active refusal was not an issue at all. When we looked at this by race and ethnicity, we find again that forgetting to take the medication was the most common reason reported by all races and ethnicities. Logistics was here, and here was active refusal. In a qualitative study conducted by Wendy Landier, where she interviewed patients and parents separately but often simultaneously, she found that all participants described barriers to medication taking, several barriers, but forgetfulness was the most common theme. And adherent teens and their parents emphasized the importance of parental responsibility as a strategy for overcoming that forgetfulness. And then adolescents welcomed or at least accepted that parental vigilance. These were the adherent teens. However, on the other hand, the non-adherent teens, they had difficulty identifying a person in that parent-teen dyad who would take the responsibility for that administration of the medication. So with this in mind, we now know that there was a critical need for adherence-enhancing interventions because lack of adherence, even to the slightest extent, was associated with an increased risk of relapse. And we found that the major barrier was forgetfulness, and then the major facilitator was parental vigilance. And with this in mind, we developed a study to focus on interventions to mitigate non-adherence. And this study had a complete intervention package, which included a multimedia interactive patient education, a web-based medication scheduling, where there was a customized printed schedules for the patients, text message reminders, and directly supervised therapy by a designated caregiver, which was usually a parent. So the patients were enrolled, there was stratified randomization, one arm only got education, and the other arm got education as well as all the other 3 components. And this is what happened. The customized instructions were in the form of using a secure, HIPAA-compliant, web-based application. It's called the MedAction Plan, where the physician in the clinic created a schedule for the patient, and they specified the dose of medication, the time when it was supposed to be taken, and this resulted in a nicely formatted calendar for the patients for each day as to what they needed to take, with a checkbox to mark off when they had taken the medication. There was a streamlined interface within this program which activated the automated text message reminders. And so with this, the patient got the message to take the number of tablets they were supposed to get at the time that they were supposed to take it, and it was signed by their physician. And this message also went to the parent, and then the parent engaged in what's called as a directly supervised therapy, and both the arms got to view a multimedia interactive patient education program. Next time when I come, I'll present the results of this. The study is not complete yet. Another very nice tidbit to this is that all of us wonder why we have to use those machines, the MEMS caps with the caps which record the date and time of opening of the pill bottles. What we wanted to see was, can we go to the clinic and ask the patient, did you take your medicine? And so we looked to see what was the accuracy of self-report of 6-MP ingestion by patients and parents. And so this was our question, how did this correlate? And we found that it did not. This is what the parents or the patients report. This is self-report. And this is what the MEMS caps tells us. So there's a difference. You see about 4 days, 3 days, 3 days across the time period. This is actually not in press, it's published, and Wendy Landier is the lead author on this paper. We then said we would like to classify patients as perfect reporters, those who said absolutely to the day the number of days that the patient had taken the medication. There were those who were called the over-reporters, which reported 5 or more days more than they had taken for at least half of the time period. And then there were others who were also over-reporters, but less than this extreme over-reporting. What we find is that what are the predictors of over-reporting? We find that race and ethnicity plays a role, lower college education plays a role, lower education plays a role, and then most importantly, lack of adherence plays a huge role in over-reporting. So I wanted to show you some of that data. Here's non-Hispanic whites, Hispanics, Asians, and African Americans. You can see the spread is wider here than here. But the most important thing is these are adhering patients. So there's very little difference between self-report and MEMS caps. And look at this wide difference between those who had low adherence between self-report and MEMS caps. And so what this showed to us was that we truly could not rely upon self-report in terms of finding out how much medication they had taken. So our next steps for this study are to develop an adherence calculator to assess adherence in a clinical setting and make the adherence intervention, if it truly works, standard of care. Let's talk about totally different. Here we're talking about what's called burden of morbidity. So this was a landmark study. It was published in 2006. It was led by Kevin Effinger, who's now at Duke, and he participated in the childhood cancer survivor study. And what he showed was that when you follow childhood cancer survivors long-term, up to 30 years out, that 41% of them will have developed severe or life-threatening chronic health conditions. A similar study led by Greg Armstrong at St. Jude Children's Research Hospital used data from their St. Jude Life study and brought children back into the clinic. And these are patients, the x-axis here has age as the time scale. And what you see is that by 50 years of age, about half of them had chronic health conditions which were severe or life-threatening. These are the chronic health conditions in the siblings. So clearly, there's a very high, steep curve in terms of the cumulative incidence of chronic health conditions. And these are not just ordinary chronic health conditions. These are congestive heart failure, second cancers, renal dialysis, those kinds of things. So these are the kinds of conditions. We're looking at osteonecrosis because of prolonged steroid administration requiring a joint replacement, looking at severe musculoskeletal deformities due to radiation exposure. We're looking at large flabby hearts because of anthracycline chemotherapy, looking at scarred lungs, which do a lot of air trapping in them. We're looking at lung cancer developing because of radiation therapy. We're looking at breast cancer developing because of radiation therapy, an ugly leukemia developing as a result of chemotherapy, and then brain tumors, again as a result of radiation therapy. So these are the kinds of severe chronic conditions which develop as a result of the treatment that we use for our first cancer. So when a patient comes to the clinic, we have to give them treatment. So there are therapeutic exposures, and these are in the form of radiation and chemotherapy. And unfortunately, they do result in adverse events. However, there are several mediating and moderating factors. Some of them include genetic predisposition, lifestyle exposures, viral infections, and then age and gender plays a role in moderating who gets certain adverse events at a higher rate than the others. And so all of these factors can be used to identify those at the highest risk, and we can then use that to modify therapeutic exposures, screen high-risk populations, and then develop risk reduction strategies. But we need to do that in the setting of identifying those who are at the highest risk so we can reduce the risk of these adverse events. So my focus today is going to be on genetic predisposition and to some extent other conditions. So here's why we want to do genetic predisposition studies. When we were younger, we used to know that, so let's talk about it this way. When in the 1990s, 1980s, we knew that when you gave a particular chemotherapy or radiation, it resulted in particular bad effects such as heart failure, such as new cancers. But we truly didn't know who developed those conditions or who wouldn't develop those conditions. So with the advent of molecular techniques, we now know that when you have therapeutic exposures, it doesn't result in the same internal dose in every patient, that the biologically active dose could be different for different patients, that it could alter the structure and function of the collateral organs which are being damaged in a different way for different individuals, resulting in preclinical disease and clinically overt disease. So this is where we focus on in terms of susceptibility in order to dissolve that black box. So we are doing this in the setting of a large national trial. It's called ALTE-03N1. It's through the Children's Oncology Group. And here what we've done is that 120 odd sites are participating in this study, and every time a new kid comes in with a particular condition that we're interested in, they identify those conditions and they then enroll them. We bank DNA and RNA from the patients who we enroll, the cases, and we also identify controls for them, who they enroll, and bank DNA and RNA from them. The goal is to study genetic susceptibility. So this is a case control study. Here are the cases, here are the controls, and we're matching them using these matching criteria: primary diagnosis, time at risk from diagnosis, date of diagnosis of the primary cancer, and then race and ethnicity. And these are the conditions that we're interested in. We're interested in subsequent new cancers that are developing these patients, osteonecrosis that I had shown you a picture of in the hip joint, congestive heart failure, and stroke. And the methodology is that all patients who participate complete a questionnaire for comorbidities and medications. Blood is drawn for DNA from the cases and controls, or if they can't give that, we ask for a saliva sample. Participating sites give us a detailed treatment history of the patients, every drug that is used as well as the doses, and then we ask for documentation of that particular condition in the form of radiology for osteonecrosis, pathology reports, echocardiogram reports, and then again radiology for stroke. So I'm going to focus primarily right now on cardiac toxicity or heart failure. So it's in the form of heart failure. The risk factors are this particular chemotherapy agent called anthracyclines, which is used in about 50% of our children with cancer. What are the risk modifiers? They are chest radiation increases the risk, younger age at exposure, young being less than 5 years of age, increases the risk, and then female sex increases the risk. This is what a normal heart would look like if it got exposed to anthracyclines. There is this spotty white areas which are the individual cells which are lysing. You can see them here. This progresses on to what's called patchy myocardial necrosis. You see all of these pink areas which are necrosed off. Then there is interstitial fibrosis. You see these blue areas which have fibrosed off. And then there is absolute disorganization of the structure, of the myocardial structure, where you see all of these blue areas. and that then presents as heart failure. So this is what happens in the patients who eventually develop heart failure after exposure to anthracyclines. There is a clear dose-response relationship. This is the odds ratio of developing heart failure, and these are the dose categories of anthracyclines. And what we find is that amongst those who've been exposed to 200 to 250 milligrams per meter squared of anthracyclines, there's a much higher risk of developing heart failure. However, there's significant inter-individual variability in risk. And here we are, when we look at each of these green dots, these are cases that have developed heart failure. This is the dose of anthracyclines, and these are the number of patients. Here we cut it at 250 milligrams per meter squared. What we find is that there are several patients who received a much lower dose of anthracyclines and yet developed heart failure. On the other hand, we look at controls and we cut it at the same 250 milligrams per meter squared, and none of these developed heart failure. We find that a significant number of them received much higher doses of anthracyclines and escaped heart failure. So this is what brings us to the question of, is there a role for genetic susceptibility? So the pathogenesis of cardiomyopathy is as proposed here, that you give high doses of anthracyclines. They have to cross the cell barrier, so drug transport comes into play. The anthracyclines could undergo a single electron reduction with the NADPH oxidase multi-enzyme complex, or they could undergo a 2-electron reduction and result in directly into myocyte apoptosis, or they could result in increased ROS production or then lead to mitochondrial dysfunction and then lead to myocyte apoptosis, then a bad and maladaptive LV remodeling, and eventually heart failure. So we worked off of this model, and here's what we did. We looked at candidate genes which were involved in anthracycline metabolism. We looked at carefully curated SNP arrays, and then we looked at agnostic genome-wide association studies. We also did functional studies as we needed. So this is what we did. We said that carbonyl reductase gene results in a 2-electron reduction of anthracyclines or doxorubicin, resulting in an alcohol metabolite. This metabolite is immensely cardiotoxic and hangs around for a much longer time than the parent drug and can result in heart failure. So we looked to see if we stratified the patients by the high-risk genotype versus the low-risk genotypes and looked at their risk of developing heart failure with increasing doses of anthracyclines, what would happen. So here is the high-risk allele patients, and here is the low-risk allele patients. So clearly there's a difference between the two. We also looked to see the carbonyl reductase activity in the tissues, and we find that those who carry the high-risk allele produce much more of the carbonyl reductase than those who have the low-risk allele, resulting in this movement along this line to form this cardiotoxic alcohol metabolite. So when we place this in the context of our model, we find that carbonyl reductase with the high-risk allele results in higher productions of the alcohol metabolite and then results in this path which leads to heart failure. We then looked at carefully curated SNP arrays. In this, what we did was, we knew that when you have only high-dose anthracyclines, it increases the risk of heart failure by 10-fold. When you add hypertension to this, it significantly increases the risk of heart failure. When you add diabetes mellitus to this, significantly increases the risk of heart failure. With this in mind, we went to a particular SNP array that had been generated by Broad and others, and we said, let's look at these prioritized lists of 2,100 candidate genes which are likely to be involved in cardiovascular risk disorders. And so we found in that a particular SNP on a particular gene called HAS3 or hyaluronic acid synthase 3, which significantly resulted in an increased risk. So GG allele, no increase in risk, all of these doses. GA, you can find a slight increase in risk. AA, a significantly increase in risk, and it happens around 250 milligrams per meter squared that these curves separate from each other. We replicated these findings, and for the interest of time, I won't go over how, but you see that they did replicate. But then we went on to functional studies, and we took hearts from a particular organization. These were hearts of people who had died in accidents, not as a part of cancer treatment, had not received anthracyclines, did not have heart failure. And we looked to see, after genotyping them, whether the expression of this particular gene was different in the two groups of alleles. And we did find that those who had the high-risk allele had lower amounts of gene expression as compared to those who had the low-risk allele. And so how does this fit into the model? When we're looking at HAS3, that has antioxidant properties. And so normally, if you have the wild-type HAS3, it has antioxidant properties, it would result in lower amounts of ROS and prevent the development of heart failure. However, as we'd shown, the gene expression was low, so it would not prevent the ROS production going down, and so we would have higher levels of ROS. Also, hyaluronic acid is found in the extracellular matrix, and it's involved in remodeling, and that could play a role here as well. We then went on to do a GWAS study, and here's the GWAS study. We found a particular gene on SELF4, it's a particular gene, a SNP, which was associated with an increased risk. We replicated these findings, and then we looked to see the gene-environment interaction. Again, the AA allele, no increase in risk, GA allele, no increase in risk, GG allele, significant increase in risk of heart failure. And I will not go into these details to tell you what this is, but I will tell you that the question we were asking was whether this particular SNP was associated with increased expression of more than one variant of TNNT2, which is associated with myocardial injury. And the reason for that is because this particular gene is associated with alternative splicing of this gene. So we took those 33 heart samples and we genotyped them, and we looked for the embryonic splicing variant, and we found that those who had the low risk allele did not have any. Those who had the intermediate risk allele had some. Those who had the high risk allele had the highest amount of this embryonic splicing variant of TNNT2. So that was how it was working. So self-mediated alternative splicing of this particular gene results in more than one isoform of TNNT2, and that results in decreased myocardial contractility. So in this summary, CBR3, HAS3, as well as SELF4 are associated with an increased risk of heart failure. And this is still just the tip of the iceberg. It's still ongoing, the investigation as to what the other components are that are associated with heart failure. So now, can we identify high-risk groups? Are we able to do that? And yes, we did look at this. We looked at the pharmacogenomic prediction of anthracycline-induced heart failure, and we looked at all the clinical mediators, and they're listed here, and we looked at genetic mediators. And what we find is that there are certain clinical mediators, such as female sex, radiation to the chest, and hypertension, which are associated with anthracycline-related heart failure. In addition, we found these three particular genetic SNPs, variants, which are associated with an increased risk of heart failure. And when we created the ROC curves, we found that if you looked at the genetic variants alone, the AUC is only 67%. When you look at clinical factors alone, it's about 69%. When you combine them all together, it approaches 80%. So this study shows it's a proof of principle that we can indeed improve the prediction when we are trying to determine who is going to be at increased risk of heart failure. The next question is, we can do all of these, but can we truly reduce the risk of these long-term complications in these patients? And so I'm going to present the findings of a study which we are conducting here. It's looking at breast cancer in Hodgkin lymphoma patients. So it's based on the facts which we know so far, that there is a straight line relationship between the dose of radiation to the breast for an unrelated cancer and the risk of developing breast cancer. So the higher the dose, the greater the risk. And those of us who've studied epidemiology, this is one of the things, that if there's a dose-response relationship, there must be causality, right? The second part to it is that risk that develops in these patients of breast cancer. So here's these patients. These are patients who had Hodgkin lymphoma, and they were followed, and here they are up to 60 years of age. and here's the risk of developing breast cancer. And what we find is that by the time they're about 45 years of age, the risk of developing breast cancer is 19%. And this risk is exactly the same as a BRCA mutation patient would have. So if you put this, the BRCA mutation cumulative incidence here, it would mirror this. The third thing to note is that if you were to give ovarian radiation to suppress the ovaries to patients who are receiving chest radiation, the risk of developing breast cancer is much lower as compared to those who didn't get ovarian radiation. So there is the requirement of internal estrogens in order to combine with chest radiation to increase the risk of breast cancer. So endogenous estrogens modify the risk of breast cancer. So if you were to give estrogen blocking interventions, we could prevent radiation-induced breast cancer in survivors. So we worked with this premise. And what we wanted to go back to the drawing board and say, you know, breast cancer risk is increased. It's similar to that of BRCA mutations. What other options exist for these girls who have received chest radiation for Hodgkin lymphoma? I mean, there are surgical interventions. We could do prophylactic bilateral mastectomy. This would reduce the risk by 90 to 95%. However, unlike BRCA mutation carriers where their parents or their mothers or other aunts and other relatives have had breast cancer and they've seen that in their families, our Hodgkin lymphoma survivors are not comfortable with this option at all. We could do bilateral oophorectomy. This would result in a 50 to 70% risk reduction of breast cancer, but it increases the risk of osteoporosis, dyslipidemia, cardiovascular risk, so it's not the most comfortable option for these patients. And plus, they want to have families, and by the time, and the risk of breast cancer, the average age that these patients develop breast cancer is about 37 years. So this is right in the middle of the time when they are wanting to have their families. So then there are pharmacological interventions. The pharmacological interventions include tamoxifen. The efficacy is there for both pre and postmenopausal, raloxifene, and then aromatase inhibitors. Both of these are approved only for postmenopausal setting. However, our patients are both pre and postmenopausal. So really, the only option that's available to us is tamoxifen. So normally tamoxifen is used at 20 milligrams daily, and it's associated with significant adverse events such as, you know, the menopausal symptoms that patients don't tolerate very well. But what's more serious is the risk of uterine malignancies, stroke, and DVT, or venous thromboembolism, which is present at a low risk, but patients shy away from this drug. Italian researchers looked at a lower dose, 5 milligrams per day, and they found that it maintained the decrease in risk of breast cancer, but the risk of AEs, or the adverse events, went away. So they weren't there to the same extent as the 20 milligram dose. And so with this in mind, we have a study which is currently completed enrollment, but patients are still receiving the drug, where we are taking girls who've received radiation to the chest and are randomizing them in a double-blinded placebo-controlled trial, where one group gets the low-dose tamoxifen and the other group gets the placebo. And our endpoints are not waiting for the development of breast cancer, which would take forever and a much larger dose, but it's an intermediate endpoint called mammographic breast density. And we're looking to see if that is changed, altered with the use of tamoxifen. So that, again, when I come back, we'll present the results. So then the final thing I want to talk to you about is we go on developing all of these studies, and we show that people have these horrible adverse events. They're clearly related to the treatments. Does this translate into changes in treatment? And yes, indeed it does. And this was a study that we published recently where we showed that if you look at death from any cause in children, we find that it was much higher in the 1970s, much lower in the 1980s, and significantly lower in the 1990s. Then we looked at death from health-related causes, not from relapse, but from other non-relapse causes. Again, higher in the 70s, lower in the 80s, much lower in the 1990s, although the separation is not as much as it is for relapse-related and other causes of death. So, are we there yet? No. this will keep us going and getting grants and publishing. But we are getting there. We're solidly on the right path. And so with this, I want to thank everybody who has participated. It truly is a big group of people who have participated in the study and provided us with their help. These are the awards which helped us through these studies, and most importantly, the patients who they and their families gave us their time and energy to help us study these questions.